Hello friends, my name is Dr. Kazmi and you're watching my YouTube channel, and today I'm going to talk about a very important topic which is usually tested in the exams as well, and that topic is the precocious puberty. So from now onwards I'm gonna make some changes in my lectures, so I would be focusing on more high yield subjects and high yield topics, and I would be specially discussing them in context of the membership exam of the Royal College of Pediatrics and Child Health. So while discussing these topics, I would be focusing on the particular aspects of these high yield subjects which are actually tested on the exams. And when I'm saying on the exams, I mean the part 1 as part 2. So the concepts which are tested on the part 1, known as the theory and application of science in pediatrics and the foundations of practice, as well as the MRCPCH part 2, which is known as the applied knowledge in practice. And with that, I would be focusing on some of the aspects of these high yield topics which are tested on the MRCPCH clinicals as well. So today's topic is a very high yield one, that is known as precocious puberty. So without further ado, let's start our today's topic. So precocious puberty means a development of puberty before 8 years in girls and before 9 years in boys. So this is a very simple definition, which is a uniform definition and is used almost in all the textbooks of pediatrics. So keep it in mind that puberty. Now you should also know what is puberty. Puberty is the development of secondary sexual characteristics in males as well as in females. And if these secondary sexual characteristics along with the physical growth, if they are manifested in either a girl before the age of 8 years or in a boy before the age of 9 years, then technically it is known as precocious puberty. Now you should also keep it in mind that usually puberty in boys appears somewhere between 9 to 14 years of age, and in girls it could be anywhere between 8 to 13 years of age. And much of this puberty, development of this puberty is dependent on the racial characteristics as well, and they say to some extent on climate as well. So that's why children who belong to the temperate regions or from around the equatorial regions, they reach puberty at a much earlier stage as compared to their cohorts which are from the the far off parts of the northern and the southern hemispheres, in other words the cold areas. So remember, in warm areas and in certain ethnicities, children, they reach puberty at an earlier age on this spectrum of either 9 to 14 for boys and 8 to 13 for girls. But by definition, again, I would say if you are given in an exam a child who has got signs of puberty before the age of 8 years in girls and 9 years in boy, then you should just understand that the examiners are testing you on the subject of precocious puberty. Now, before we start, you need to know a few important things about this topic, and that is, let me quickly go through that. Yes, you should know that thelarchy, which is the actually development of breast, okay, and increased growth velocity in terms of height before the age of 8 years in girls and before 9 years in boy is precocious puberty. So thelarchy means development of breast. So we know that in puberty there are so many things. So there would be development of breast, there would be development of pubic hair, and there is increase in genital size as well. But in particularly thelarchy, so isolated development of breasts, okay, even if that is the case and if it is associated with a growth velocity before the age of 8 years in girls, and if the genitals are developing in boys before 9 years of age, that also suggests precocious puberty. Now remember, in girls most of the cases of precocious puberty are idiopathic, but in boys most of the cases have got an organic cause. And that's why if you are dealing with, in clinical practice, you are dealing with if the boy who's got precocious puberty, then you need to find out what is the underlying pathology, and such cases would require urgent referral to a pediatric endocrinologist. Sometimes you might be given this thing in the exam and they might be asking you, a boy who has got genital development before age of 9 years, so what should be your next step, then obviously you have to select that you need to refer them to pediatric endocrinologist, because pediatric endocrinologist then would be looking into the reasons, whether they have central reasons or whether they are peripheral reasons for that, and he would know how to best manage this type of condition. Also keep it in mind that many cases of precocious puberty in girls who are over 6 years of age have benign causes. As I said, like most of the time when you are working up these girls, you won't be able to find a cause, and we call them as idiopathic precocious puberty. But in a rare number of cases, you will find some serious pathology as well. The other thing is that it can be very hard to discuss it with the patients. Obviously, people are shy to discuss these topics. So it's very important that as a pediatrician, you should invite them so that they can share their concerns with you, and you can find you can work up a proper plan for them. It's also very important that you do a timely referral, because time is everything in precocious puberty, and if there is any uncertainty about the development of things, so that could be discussed with the endocrinologist. So it is very, very important that these kids are referred in a timely manner. So again, 2-3 definitions that you should also always keep it in mind, and should be very clear about these definitions. So as I said earlier, the definition of precocious puberty is that if the child has got signs of secondary sexual development in a girl before 8 years or 9 years in boys, that is precocious puberty. And there are a few other definitions which you should understand: thelarchy, adrenarche, and menarche. Some also call them thelarchy, adrenarche, and menarche. It doesn't matter how you pronounce these terms, you should understand what they mean. So thelarchy means development of breast. So this is a term which is just reserved for girls. So the breast develop from from a simple breast bud, and as they develop the mounds and they ultimately go to the adult stage, this whole process is known as thelarchy. Adrenarche is development of pubic hair, while menarche is the beginning of the menstruation or menstrual cycle. So thelarchy, development of breast, because the hormones that are usually responsible for that, they are estrogens. So and adrenarche is mostly the reason for that is usually the peripheral hormones, and the same goes for menarche. So these 3 terms, you should understand what they mean, and I would be discussing how these things they develop over the time scale. And for that, it's very important that you should understand the Tanner staging. So Tanner staging is usually given in the exam. There is also a high yield topic. It's very frequently tested in especially in MRCPCH part 2. So they will give you certain parts, like somebody who like a boy who's got, let's say, a testicular volume of let's say 6 mils, and he's got Tanner stage 2 or 3, development of the pubic hair. So they would ask you what could be the reasons for that. So it's a very high yield topic. So let's move on and discuss Tanner staging. So Tanner staging is used for staging puberty both in boys as well as in girls. So there are 5 stages of Tanner staging, starting from 1 to 5. 1 is the prepubertal, and stage 2 and 3 are commonly known, GPs call them stages which are known as in puberty. So if somebody is exhibiting the features of stage 2 and stage 3, they say they are in puberty, so they are in the process of going through the puberty. While the stage number 4 and 5, usually they come at the end. So when you find somebody who is in this stage 4 and 5, you usually say them they are completing puberty. So they have gone through most of the things that they develop in puberty, and they are usually at the end. So they are almost completing their puberty. So usually the first thing that develops in males in Tanner staging, if we go from 1 to 5, the first thing that develops is testicular volume. So from a pre-pubertal volume of 3 or less than 3, okay, so it will start growing. So the first thing is testicular volume. That is then followed by the development of the pubic hair, and then increase in genital size, and then finally at the end you get more of a male pattern of hair, axillary hair, development of hoarse voice, along with the appearance of the facial hair. In girls, usually the first stage is the development of the breast bud, and after that is the development of the pubic hair, which are usually sparse, and then they become dense, and with that the breast develops. So it's most from the breast bud, a mound develops, then it grows, and the glands they develop, and finally in stage 4 and 5 you've got more often the adult pattern of the breast tissue. So this is how Tanner staging is classified. Now moving on to types of precocious puberty. So keep it in mind, again there are two types. So one is the what we call as central, which is also known as gonadotropin dependent precocious puberty, or GDPP. The other is known as GIPP, which stands for gonadotropin independent precocious puberty, or also known as peripheral precocious puberty. So the central one, the causes lies somewhere in the brain. So it would be either the hypothalamus, or it might be the pituitary gland, or it might be any other part of the brain which might be responsible for over secretion of the hormones which are responsible for causing puberty. So all of them are grouped together and called as gonadotropin dependent precocious puberty. The other one is the gonadotropin independent precocious puberty, where most of the causes are peripheral. So increase in peripheral hormones like being secreted by ovaries or by testes or by adrenals, the excess of those hormones can also lead to the appearance of certain secondary sexual characteristics, and that is what we call as gonadotropin independent precocious puberty. So the first step in workup of any case who fulfills the criteria for precocious puberty is to classify. After you have done the Tanner staging and everything else, then the next step would be whether it is central or gonadotropin dependent, or whether it is peripheral or gonadotropin independent. And I will tell you in a moment how we classify them. Okay, what are the tests on which we classify them? So some of the causes of gonadotropin dependent and independent precocious puberty. So you can see here in the screen. In girls, one of the most common cause of gonadotropin dependent precocious puberty is idiopathic. Idiopathic means there is no cause. So somehow the gonadotropins are released in increased amount, which act on their target organs and leads to development of the secondary sexual characteristics. Different research have shown different things, and they say that genetic and environmental factors are most likely to contribute, and usually there is a family history of precocious puberty in such families where you get kids, so one of the parents might have precocious puberty, so there might be somebody in every generation who might be having precocious puberty. So environmental factors, genetic factors, racial factors might be responsible for that, and this is what we call as idiopathic gonadotropin dependent precocious puberty. We are not able to find a cause. Then the second category, which is usually rare, but still you can have that can cause precocious puberty, is where we have got causes in the central nervous system. So central nervous system tumors, which especially those which are involving the hypothalamus, like the pituitary hematomas or gliomas, or malformation of the hypothalamus, or CNS germinomas, or if there is any other space occupying lesion, meningioma. It could be a congenital brain disorder, it could be acquired injury or infection, a past history of meningitis, hydrocephalus. So all these central nervous system causes it's not necessarily that in all cases they would be causing precocious puberty, but they have got a tendency to cause them, and one shouldn't be astonished if you get these things as a cause of precocious puberty. Some of the genetic syndromes which involve the central nervous system can also give you precocious puberty, and just want to discuss the neurofibromatosis type 1 and Stouch-Weber syndrome, and another condition which is usually related with tuberous sclerosis. They've got characteristic manifestation. Neurofibromatosis, you've got Café-Olé spots, there could be optic gliomas, axillary freckling, and Stouch-Weber syndrome. you have got the bovine stain, and in tuberous sclerosis you've got the ash leaf spots, and then you've got tubers in the central nervous system. So they've got their own very characteristic manifestations, and they can be associated with gonadotropin dependent precocious puberty, or in other words central precocious puberty. Now the other term is gonadotropin independent, in which you find reasons which are there in the peripheral organs. It could be the ovaries, it could be the adrenal glands, or it could be the testes. So viralizing tumors, for example, androgen producing ovarian or androgen producing adrenal tumors, or androgen producing Leydig cell tumors of the testes, or human chorionic gonadotropin producing tumors which might be there in the liver as well. So they can cause precocious puberty. Congenital adrenal hyperplasia, that can have different types: 21 hydroxylase deficiency, 11 beta hydroxylase deficiency. There are some other ones as well. So blockades in the enzymatic pathways and in the hormone pathways can lead to increased production of the androgens, because if a particular type of hormone is not being developed because of a blockade of an enzyme, so it would be shunted towards another pathway, and usually that leads to increased androgen production. And these androgen production can have a viralizing effect on both boys and girls. So boys can have precocious puberty, girls can also have precocious puberty, and can have male pattern of the hair. So, and another one rare reason for precocious puberty is McCune-Albright syndrome, especially in girls. So McCune-Albright syndrome is a genetic mosaicism. It's not an inheritable condition, and what it does is that it leads to an overproduction of hormones from different organs, and it leads to formation of ovarian cysts, which are constantly producing estrogens. So in McCune-Albright syndrome, in which what you get is cafe-au-lait spots, you also get polyostotic fibrous dysplasia of the bones, so that can lead to fractures and deformities of the bone, and precocious puberty. So these are the three things which are hallmark of McCune-Albright syndrome. One is precocious puberty, the other is polyostotic fibrous dysplasia, and number three is cafe-au-lait spots. So these are some of the causes of peripheral or gonadotropin independent precocious puberty. Now coming down to the symptoms. So what would the symptoms? So boys and girls have different types of symptoms. In a boy, usually if there is pubic hair, development of the pubic hair, or development of the genital enlargement, whether it's the testes or whether that's the penis, in an age less than 9 years of age, that would be, as I told you earlier, that is the definition of precocious puberty, and that's how they would present. In girls, they could present in different combinations. So they can present isolated breast development less than 7 years of age, or they can have pubic hair less than 8 years of age, and or start of menarche less than 10 years of age. So you should understand these things, because in girls especially it's a bit tricky, because once the development of the secondary sexual characteristics starts, so some things they start in the beginning and something they start after that. So as I told you, that it would start from the development of the breast, followed by the pubic hair, and usually menstruation occurs 3 to 4 years after the start of the puberty. So that's why less than 7 years if there is breast development, less than 8 years if it is development of the pubic hair, or if less than 10 years it's start of menstruation or menstrual cycle, then you should be thinking of precocious puberty in that. And again, we also see if the symptoms are concordant or discordant. Concordant mean that the symptoms are appearing in the order in which they should normally appear. The only thing is that they are appearing early. Discordant means that you are getting one factor that's being developed. Like for example, it's just the pubic hair that are developing, but not the other things, like the breasts are not developing. Or it might be that the breasts are developing, but the pubic hair and menstruation has not occurred. So it could be discordant as well. I will discuss that in later on. Now, how we approach such cases. So meticulous detailed history is very, very important. So you should take a history of when they first noticed these characteristics which appear, the order in which the things they have appeared, and it's also important to know any history of previous central nervous infections, any history of trauma to the head, any family history of such things, a history of any drug, especially hormonal drugs for any condition or thing. So you need to ask about all these things in a detailed history. Then is a clinical examination. In clinical examination, it's very important. Once you think that they are fulfilling the definition for precocious puberty, then the next step would be to stage them on Tanner. So it's very important that you should know the Tanner staging from 1 to 5. That 1 is prepubertal, 2 and 3 is in puberty, and 4 and 5 is just completing puberty. And it's also very important that you plot their height and weight centile charts, because if puberty is associated with increased in height, so usually you're thinking about the central causes. If it is just associated with weight, not height, I think you might be thinking of peripheral or gonadotropin independent precocious puberty. So it's very important to plot a proper height and weight centile charts for the child that you are examining. Investigations are coming down to the investigations. Now, investigations, there are different types of investigation which are done. The first important investigation, or which is used as a screening tool, is luteinizing hormone. So if in examination you are especially in foundation of practice, that is MRC PCH part 1, usually they throw up a question where they will give you a scenario of somebody with a precocious puberty, and they say what is the next best step for workup of this child. So luteinizing hormone is the best screening tool for central precocious puberty. So if the features are that of precocious central precocious puberty, then your answer should be luteinizing hormone is the best screening tool. So you should also always keep that in mind. Now the other thing is that let me highlight this one. So you should understand that luteinizing hormone is the best screening tool. Now after that, you should also be doing the FSH and LH levels. It's very important to know the FSH and LH levels and testosterone and estradiol levels. So you have to do a complete hormonal profile and see which hormones are in excess. And once you have done that, then the most important test to differentiate between central and peripheral, or in other words, gonadotropin dependent and gonadotropin independent precocious puberty, is gonadotropin releasing hormone or of its analog stimulation test. So this is the most important test to differentiate between central and peripheral precocious puberty. So sometimes you might be given a question in exam where they are saying, okay, fine, ABC has got this characteristics, okay, which are actually telling you that the child has got precocious puberty. What test would you do after that, okay, to differentiate between the central and the peripheral? So the answer should be gonadotropin releasing hormone stimulation test. So in gonadotropin releasing hormone stimulation test, you either give the gonadotropin releasing hormone or one of its analog. So that is given to the child, and you then look at the response of the gonadal hormones. So normally, if you recall your knowledge of physiology, so what happens is that the hypothalamus secretes gonadotropin releasing hormone, and gonadotropin releasing hormone acts on the pituitary gland, and the pituitary gland then in turn secretes FSH and LH, and then this FSH and LH that goes down acts on the gonads and causes in turn causes the ovaries to secrete estrogen, or causes orders the testes to produce testosterone, okay, which then are responsible to exert their effects. So normally if you give them gonadotropin releasing hormone, what should happen is that there should be increase in the FSH and LH levels. So when you do the gonadotropin releasing hormone stimulation test, so you give the gonadotropin releasing hormone on one of its analog to the child who is being investigated, and once you have given that, then you would measure the level of the pituitary hormone, especially the luteinizing hormone. So either you would give the gonadotropin releasing hormone or you will get one of its analog. So if there is central precocious puberty, so what would happen is that once you have done the stimulation test, there would be a rise in LH. There would be rise in LH, and So once you've done that and you see a rise in LH level as compared to the baseline, you can say that this is central precocious puberty. But if you have given this gonadotropin releasing hormone or one of its analog and there is no rise in the LH levels, then it confirms that the cause is there in the periphery, or it's gonadotropin independent. Why? Because there is already something at the periphery which is leading, which is causing an increase in the peripheral hormones, and because of that the central axis is suppressed. So even when you are giving them the gonadotropin releasing hormone, it would not lead to any rise in LH. Why? Because the axis has been suppressed by the increase in the peripheral hormones. So keep it in mind that if you do the gonadotropin releasing hormone and it leads to rise in the LH, then this is central precocious puberty, and if it doesn't lead to any rise, then it is the peripheral one. So this is how you differentiate between central precocious puberty or gonadotropin dependent and gonadotropin independent precocious puberty. In certain conditions like premature thelarchy or premature adrenarchy, where just there is isolated development of the breast or isolated development of the pubic hair, you would see that predominantly it's not the LH, it would be the FSH that would increase when you give gonadotropin releasing hormone, and there will be no effect in case of premature adrenarchy. But nevertheless, keep it in mind, the gonadotropin releasing hormone stimulation test actually differentiate between the gonadotropin dependent and gonadotropin independent precocious puberty. Other things that we normally we would investigate these challenges with bone age. So bone age is usually advanced in cases of precocious puberty. Thyroid function tests are also very important because hypothyroidism can lead to precocious puberty. It's very important as a part of the workup that you do the TSH and the free T4 levels. MRI brain. So if there is one confirmative test, especially if you are given a case scenario of a boy with central precocious puberty, your answer should be MRI brain, because I told you that in cases of girls, most of the times the cause is idiopathic, but for boys it would be very rare that it is idiopathic. Most of the time they would be having an organic reason. So if somebody presents with what we call as concordant central precocious puberty, or you're thinking of that, then next step should be you should be doing an MRI brain to find it might be a pituitary hematoma, it might be hydrocephalus, it might be something there in the brain. And along with that, especially in the gonadotropin independent precocious puberty, it's very important that you do a complete abdominal and pelvic sonography. You also do a testicular sonography to see if there is any testicular mass which might be secreting excess of the male hormones. So it's very important to do complete ultrasound of the abdomen, pelvis and the testes or scrotum. Now coming down to the treatment. Now treatment, as we say, is treatment of the underlying condition. So if there is anything in the brain, like for example if there is a craniopharyngioma, you have to remove it. Pituitary hematomas are usually not treated surgically because it's quite risky to remove them surgically, so then medical treatment has to be given. But keep it in mind, the latest trends are that you only treat them if there is an evidence that the adult height might be compromised. So basically what you worry more is the height. So in such cases, if you think that the adult height is going to be less than what their target height should be, then that becomes a case to be treated with different types of medications. Or if menstruation starts before 6 years of age, because that can have devastating effects on the mental and health of the children, can have issues with social interaction with their peers as well. So it is very important, if that starts before 6 years of age, that is another indication for treatment. Or if it is very distressing for the child and for the families, and that is taxing their mental health, so then in that case it should be treated. Normally they say if there is pubertal development, if it develops rapidly over a period of 6 months. So if it is very rapidly growing, like very quickly, while you are reviewing them, and it's just progressing, then it also becomes a case to be treated. So if these conditions are fulfilled, then the latest trends are that we go for the treatment. If it is not, most of the times we just follow them serially. So we'll just observe them. and we would follow them. So if in case while following them up, if they meet one of this criteria, we would treat them. If not, we will just leave them, we will just observe them. So that is the crux of treatment these days, that the treatment has become very much conservative, and the trend is not to treat unless and until there is evidence of menarche before 6 years of age. It is socially very distressing, it is mentally very distressing for the child and for the family, or if the progression is very quick. So if the progression is very quick over 6 months, you have to treat it. Now the different types of medications that are used for treating this are what we call as gonadotropin releasing hormone agonist, and they come in different names. They are leuprolide, they are triptorelin, gosirelin, buserelin, and histrelin. So these are different types of gonadotropin releasing hormone agonist. They can be either given in the depot form. Some of them, they also come in the nasal spray form, and they can be given. Now so it becomes very counterintuitive to think, why are we giving gonadotropin releasing hormone agonist? Because from your level knowledge physiology, you know that gonadotropin releasing hormone is gonna affect the pituitary gland and it would just order it to produce more hormones. So why are we giving that when there is already an excess of hormone? Now the answer to this lies that gonadotropin releasing hormone is actually released in a very pulsatile manner. So it is not a continuous sort of a flow from the hypothalamus. It comes in spurts. So it's a pulsatile manner. So when you give them the exogenous gonadotropin releasing hormone agonist, so in the beginning it would act on the pituitary and they would produce lots of hormones. So there would be a temporarily what you call aggravation of the symptoms. So that's why when you are starting them on the treatment, it's very important you tell them that, okay, fine, I'm going to start them in treatment for the next few weeks to months. There would be an aggravation in the symptoms. But what happens after that? When you are constantly, giving them exogenous, so the receptors, they are down regulated. So the receptors on the pituitary gland, which are responsible, where this gonadotropin releasing hormone agonists are acting, it will be down. So there will be less receptors. When there will be less receptors, the endogenous as well as the exogenous gonadotropin, it would have no receptors to act. So in turn, the release of hormones from the pituitary would go down, and as it goes down, it would lead to further decrease in the peripheral hormones as well, and that's how this condition is treated. But nowadays we have got some newer treatment as well, and this is what we call as gonadotropin releasing hormone antagonists. So in antagonists, what they do is they would simply block the receptors on the pituitary gland, and the gonadotropin releasing hormone, it will not be able to exert its effects. So gonadotropin releasing hormone antagonists are the new modality. They are the new therapeutic agents which are being tried, and they also have shown promising results. Now the question is, once you have started treatment, for how long you should treat the child? Well, you have to treat and keep on treating till the child reaches an age where you think, well, this puberty, the stage that he had reached, that is acceptable at that age. So something, let's say you started him on 10 years of age, but that should be something which should come at 14 years of age. So you treat him till he reaches 14 years of age, because this is now normal for 14 years of age, and you will stop over there. So just keep that in mind. So in a nutshell, to summarize all this, remember, precocious puberty is if puberty develops before 8 years in girls, 9 years in boys. Remember, central precocious puberty is because of premature activation of the hypothalamic pituitary axis, increase in gonadotropin releasing hormone, and is more common in girls. The younger the kids, where the precocious puberty develop, remember, the higher the chances of finding an underlying organic reason for that, or underlying pathology. Hypothalamic hematomas are the most common tumors causing precocious puberty. It's not craniopharyngioma, remember, it's hypothalamic hematomas. Gonadotropin levels are elevated in central precocious puberty, and they are suppressed in the peripheral precocious puberty. Keep that in mind. So this was in a nutshell the topic of precocious puberty, and let's go through some practice questions which would give you an idea what types of questions are asked and what should be the answers. So the first practice question is that, let's say you've been given a case scenario in an AMQ where there is a 9-year-old boy. He's got they gave you this scenario that he's got 9 mils of testicular volume and he has got Tanner stage 4 development. So at 9 years of age, a child who's got 9 mils of testicular volume and has got Tanner stage 4 development, that is almost completing puberty. So which one test would be diagnostic? He is a boy, he is showing signs of central precocious puberty. One test that would be diagnostic would be MRI brain. So MRI brain, because I told you most of the time there will be organic reason, it will be there in the brain, you have to do an MRI brain. Question number 2. A 2-year-old girl has isolated bilateral breast development and rest of the examination is normal. So at 2 years old, just some small isolated bilateral breast development, rest of the examination is normal, there is no other signs of precocious puberty. What would be your advice to the parents? Now this is what we call as isolated premature thelarchy, and it's quite common in girls between the age of 6 months to 2 years. Or some books say even 2.5 to 3 years. So it's quite common in this age, and your advice to the parents is just to give them reassurance. This condition goes off on its away by itself, so there is no point in treating this condition. It's just an isolated condition, and your advice to the parents would be simply reassurance. Then the third question, a 7-year-old girl is brought with complaints of early breast development, and you are given this picture. So if I just to this picture, have a look at this picture. So what you are seeing is a 7-year-old girl has got premature thelarchy, and if you see, you can find some spots, okay, over here and over here. These are cafe au lait spots. So cafe au lait spots with premature precocious puberty. Remember, you should keep McCune-Albright syndrome. So if it is associated with fibrous polyostotic dysplasia, then you are thinking of McCune-Albright syndrome. So the most probable diagnosis in this case is McCune-Albright syndrome. And question number 4 is an otherwise 8 years old healthy boy has testes measuring 27 millimeter in length. So what would be the most appropriate next step? You are given a condition in which a boy, 8 years old boy, has got testes measuring 27 millimeters. So 27 millimeters is greater than the cutoff level of 25 millimeters. So the 4 ml is equal to 25 millimeter, and it is greater than that. So this is precocious puberty. What would be the most appropriate next test? So the most appropriate next test would be, the best screening test is the LH level. So you would be doing the LH levels to see if they are raised or not. So that would be the appropriate answer to this question. That would be LH. So my friends, this was a short lecture on precocious puberty. I have not gone through each and everything in precocious because it's very wide, it's a very broad subject. I've just tried to focus on the very high yield concepts which are tested on the exams. So you should be keeping these things in mind before you go for the exam. So I hope you have enjoyed the lecture. If there are any questions, queries, comments, you can just drop in your question comments in the comment section below, and I'll get back to you to answer them. Thank you very much. Bye bye.